Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan, and it's a pleasure to be hosting this podcast, and thanks to everyone for listening in. As I always do, I'd like to start out with a brief explanation of the Healthcare Labyrinth website at healthcarelabyrinth.com. First, we do a daily weekday news feed where I comb about 24 healthcare sites, provide links and some summaries and some editorializing on the issues of the day. So that's daily weekdays at the newsfeed tab. We also, at the blog tab, have 2 blogs per week that we write on various issues. And finally, at the podcast tab, of course, we have our podcast, which comes out weekly. You're listening to it now. You may be on the website, or you may be at one of the leading websites or apps out there for podcasts. So again, come to the Healthcare Labyrinth website, healthcarelabyrinth.com, each day for important news. I would also let you know that you can purchase my book via the website. The book is called The Healthcare Labyrinth, and it is available in print book, audiobook, and ebook form. So let's get to the topic of today's podcast, and it is about value-based care payments and arrangements, and I'm going to explain those. Now, I want to tell you first that I'm not really going to go into the arcanity of some of the value-based payments that we see today in the Medicare fee-for-service world or even in the commercial world. I'm going to briefly touch upon them. But not go into great detail. The main purpose of this podcast is to go deep into what I call value-based care arrangements between health insurers or payers and providers out there, and how these are beginning to take hold and will really form the basis for payment in the future between insurers and providers, and also hopefully help reduce cost and improve outcomes. So let's get right to it here. So what is really the purpose of value-based care payments and arrangements? Well, VBC payments and arrangements are really meant to move from what is known as the fee-for-service transactional payment system to one really that prioritizes reimbursement based on efficiency and quality. So what do I mean by transaction payments? Well, these have been around for many decades. They pretty much form the foundation of our healthcare system back in time. And the truth is that fee-for-service payments really are still very much the majority of payments overall in our healthcare system. And they probably will remain to some degree, even if we do introduce value-based care payments and arrangements. So what does it mean by transaction? Well, what it means is that payments are made or a fee is paid for each service transacted in the healthcare system. That can be the case, really, frankly, no matter where we are in the healthcare system. So let's talk about a couple examples. Say we go to our primary care physician, which, by the way, is more likely to now have a VBC payment. But let's pretend for the time being that it is one of the doctors that are paid on a fee-for-service transaction basis. Well, he or she, our PCP, will be paid a fee by the insurer for the visit, as well as a fee for each of the other services that he or she provided to us when we went to the primary care physician's office. Similarly, let's say we had to go visit a specialist for diabetes or cardiac issues or something like that. That specialist would also be paid a fee to see a member of a health plan, as well as other fees for additional services that might be rendered. The doctor may engage in certain blood work, for example. The doctor may essentially do some other assessment of the conditions of your heart, and those would be chargeable fee transactions along with the actual visit to the specialist in his office. A surgeon is another good example of someone who would be paid a fee for performing an operation in a hospital or perhaps a freestanding ambulatory care center, or potentially even in his physician office. A lab or an imaging facility similarly receives such payments for services. A hospital receives a fee for each inpatient and outpatient stay or an encounter as well. And obviously, the surgeon, as I noted, is paid separately. The fee-for-service transaction system is so grotesque that in some cases, a hospital could actually get paid for each line item of service provided during a stay, depending on the arrangements between a hospital and a health plan. So that's a sort of brief overview of what the transaction system is and why VBC payments are meant really to move from that transaction system to one driven by efficiency and quality. So what are really the issues with transaction payments? Well, by their nature, they really result in a few things. First, they tend to drive utilization often when it is not necessary. Under a transaction system, the doctor is more a provider furnishing services, and therefore the more services that provider supplies, the more he or she is paid. Now, many would argue that a good doctor would not be furnishing services that are not needed. Well, that may be the case in individual circumstances, but it does seem to show that in a fee-for-service transaction system, by and large, a provider furnishes much greater numbers of services than perhaps in other forms of payment. So human nature probably drives that provider to furnish services that may not be absolutely necessary. Second, such a system can also be very, very inflationary. And why is that? Because if a provider receives a payment for each service provided, each and every year that provider is also incented to raise those transaction prices annually. And therefore, costs tend to go up much more than they do in other kind of payment systems. Third, these transaction payments are not linked at all to efficiency or quality outcomes. Once the service is done, that's it. The doctor's been paid. He really doesn't have any other obligations. There are really no long-term considerations. And that tends to mean disparate care and not care-managed care. And therefore, we see even higher prices within the overall healthcare ecosystem. So as I noted, we may never escape transactional payments entirely. They probably do have a place in the system, and creating alternative payment structures for some of those services would be very difficult. But more and more insurers and government programs are seeking to move from that transaction system now to what's known as value-based care payments or arrangements. So where did this all start? Well, VBC reforms are really being driven by the Centers for Medicare and Medicaid Services, or CMS, in the traditional fee-for-service Medicare and Medicaid programs, and also by Medicare Advantage insurers, Medicaid managed care insurers, and also by commercial payers. So it's sort of a reform process by both private insurers and government regulators like CMS and state Medicaid agencies. And again, it's grounded in trying to break that transaction payment system and focusing provider payments on efficiency and quality. VBC payments can change the paradigm from getting paid for each service to focusing again on that cost effectiveness and quality outcomes. I'm really convinced of that. It will take a great deal of time. It will take a great deal of refinement, but I really do believe we'll get there over time. So let's first talk very briefly, as I said, about VBC payments linked to services or groups of services. Again, I'm not going to spend a lot of time here, but in this case, payment schemes revolve around savings and sometimes quality outcomes centered on a given service or a group of services. A good example is some CMS programs and private insurers are paying a set amount for a given service or episode around a group of services. Let's take one good example that's out there, knee replacement surgery. In the past, every provider servicing somebody, a patient who had knee replacement surgery, would be paid a transaction payment. The hospital or the ambulatory surgery center would get their payment. The physician administering the surgery would get their payment. An anesthesiologist and perhaps other doctors involved in the surgery would get their payments. A nursing home or a home care agency that provided rehabilitation would get a payment, and so on and so forth. So you could have a myriad of different people receiving payments for that knee replacement surgery under a transaction form of payment. But in the VBC form of payment here, a hospital and other providers would be paid a set global fee for all aspects of surgery as well as the follow-up for the knee replacement. This would include the hospital or ambulatory surgery center, the surgeon, and providers that, again, perform that needed rehabilitation and other follow-up care. Usually, these VBC global payments work best for providers related to each other, such as a hospital or a health system that owns the various entities so that they can ensure collaboration for both the surgery and the follow-up care. The global payment is meant to ensure the providers, again, collaborate and ensure the most effective and quality care is rendered for that knee replacement surgery. And that, again, is the model being used, for example, in global payments. They apply to other kinds of hospitalization. They also apply potentially to individual services as well. How about drugs for cancer treatment? Let's follow up this example. While VBC payments are very nascent in the drug industry, a drug company could be paid a VBC payment tied to the outcome of taking a drug. It also might include providers that participate in such care as well, for example, complex cancer care. In this case, the drug maker and the providers are paid more if the cancer is controlled, for example, if this is cancer treatment. They get less if the outcome is less certain. In this way, cost enters the picture too. While the drug may be expensive, a good outcome has the chance of reducing future costs. And that could be taken into consideration in that example of cancer treatment. In other cases, drugs for other disease states and conditions could also be paid based on these VBC models. So just in summary related to VBC payment, I've given you a good example of a VBC payment for more of a traditional medical service in knee replacement surgery. And then I've also sort of reflected a bit on a drug use case for VBC payment. So that's sort of a good example. As I said, there are a myriad of other ways that VBC is being brought to substitute for transaction payments in the Medicare and the Medicaid fee-for-service system, and even in the commercial world. But that just gives you a little bit of foundation on the VBC payment aspect. So now I'd like to jump over to what I call the comprehensive VBC arrangements that occur between insurers and providers or provider groups. These really form the comprehensive financial arrangement between the insurers and the providers. They are much more substantive, they're much more far-reaching, and they go well beyond just simple services or episodes of care like we see in VBC payments in particular. They are also much more holistic, and they really center on a payment or financial structure to encourage the cost effectiveness and quality of the care that is given to the assigned member panel from the insurer to the provider or provider group. So there can be various approaches in this more comprehensive framework. A hospital or a group of providers could be held to cost savings and quality outcomes and be at risk for fee-for-service payments or upfront payments if they do not hit goals of cost effectiveness or quality broadly across the membership base. A good example of this is certain pay-for-performance programs, which perhaps are a little more narrow, and the accountable care organization pilots in Medicare fee-for-service. When it comes to health plan comprehensive VBC arrangements, these are usually in a couple of different forms between the insurer and the provider. First, let's talk about a more basic one, but again, it's fairly broad in given that it's talking about the holistic care of a member or a group of members. But in this case, it's called capitation arrangements. And these are usually with primary care physicians, but could also be with multi-specialty groups of primary care physicians and other specialists. PCPs in this case usually are given an upfront capitation, which is known as a per member per month fee for each assigned member to that PCP's panel from the insurer. And so essentially they get this per member per month fee times the number of assigned members, and that is the capitation that the health insurer pays the provider or provider group for those members. For that global payment, the PCP takes care of all of the primary care needs of the assigned membership, including most in-office simple testing. Sometimes additional payments are made outside of the capitation arrangement because, again, VBC is rather new. For example, a provider or a group of providers may also receive some additional fee-for-service payments for given services, but they also may be paid a fee-for-service payment for quality achievement or other outcome-related service events that are done. But by and large, that capitation for that global membership of this to the assigned provider or group of providers is the main way of driving lower cost and quality by the insurer for that group of members. A much more mature way of reimbursement is what is known as risk funds or risk sharing. And these can also come in numbers of different forms. They can be partial risk funds, they can be global risk funds. These are usually, again, with primary care physicians, but they could also be with multi-specialty groups and even with hospitals and other health systems that are sort of known as PHOs or provider and hospital organizations. Under both state and federal rules, insurers can enter into these partial and global risk fund arrangements with providers, whereby providers take on some or all of the risk of the costs of the member's care annually. Insurers negotiate a percentage of premium, which is deposited into a fund for each member for the in-scope services, and this serves as the amount at risk. Good example. Let's say for every dollar that the insurer receives for the assigned membership to the provider or group of providers, the insurer gives the provider or provider group 80 cents of that dollar or 75 cents of that dollar to basically manage the in-scope services in the agreement. And again, that's the amount at risk. Doing better than the amount at risk might mean the provider or provider group gets all or a portion of the remaining dollars in the fund at the end of the year. Doing worse than the amount at risk means the provider pays all or a portion of the dollars needed for the care. And so that is sort of a brief explanation of how the risk funds work. So the rules and laws provide for safeguards that the insurer must follow if they enter into these partial or global risk funds. These include only entering into such arrangements with a provider or a group that is large enough to handle all of the financial risk. Oftentimes, what occurs is the provider itself or the insurer purchases stop loss insurance for the provider's potential exposure, and that becomes an expense against the risk fund. As an alternative, the plan may limit overall risk in various ways. So, as I indicated, these partial and global risk funds can have numerous flavors. So, number one, the provider may be at risk only for certain services. As an example, inpatient care, which is very risky, and even retail drugs might be outside of the risk fund, and the provider is only responsible for other medical service areas. In other cases, the provider may benefit from the upside only, the savings against the target, and not the downside, paying for a missing target. The provider may also pay only a portion of a downside, and maybe they also get only a portion of the upside. But in some arrangements, the provider is big enough and has incentive to work on both quality and cost effectiveness issues to be at risk for 100% of the downside, and the provider or provider group would retain 100% of the upside. I want to note that quality achievement usually plays a role in these arrangements, whereby providers are penalized for missing targets or receive added revenue in the fund if quality goals are achieved. So again, both financial cost effectiveness as well as quality achievement is usually part of the overall rubric of partial and global risk funds. So where may VBC go in the future? Well, I believe we will definitely see both VBC payments for given services or episodes of care, as well as master provider insurer VBC arrangements continue to grow. There's a lot of impetus from CMS to definitely pursue the growth of VBC payments for services and episodes in the Medicare fee-for-service world, as well as in Medicaid fee-for-service. They are very, very determined to get a majority of payments based on VBC. They say they're there. They will continue to grow it a great deal, I believe, in the future. When it comes to the provider-insurer VBC arrangements, there's no question that that will continue to grow as well. These kind of arrangements tend to be very mature in certain markets, largely those very sophisticated urban markets, and they will clearly become the majority of transactions in these markets soon. I also think you'll see VBC arrangements grow in some other areas that are not as traditional, as these VBC arrangements are sort of matured in whole in these more urban areas. So they will expand even into some other more suburban or rural areas, as an example. At the same time, I think it's important to note that whether we're talking about the payments or the arrangements, that they can have their downsides. There's no question about it. Many providers are complaining about some of the reimbursement reductions or penalties that they see with some of the VBC payment pilots in Medicare fee-for-service and Medicaid fee-for-service. Even in the value-based arrangement side with providers and insurers, you certainly can have issues related to those arrangements. As an example, in times of major medical expense and utilization increases, or when rate increases in government programs, as an example, are low, the impact of VBC is felt both by the insurer and downstream providers. As an example, downstream providers' partial and global risk funds essentially dry up when medical expense and utilization is high and rate increases are low. And their upside incentive is not there, and the riskier the downside potentially becomes. We are certainly seeing this today in MA, given rate and utilization and some of the regulatory trends. So that is something to watch for as well, for sure. In general, though, I think VBC payments as well as VBC arrangements are the wave of the future, because it's really the only meaningful way, in my view, to get rid of that fee-for-service transaction system and emphasize cost effectiveness and quality in our healthcare system. With that, I hope you enjoyed today's podcast, and I'll see you on the next Healthcare Labyrinth podcast. Take care.